Good afternoon. Thank you for joining us virtually for today's second day of the February 22 NVAC meeting. Yesterday was an interesting and productive day, and I'll summarize my take-home points in a few moments. I'd like to thank you, Ann, and the NVAC team for your work in planning this meeting and supporting the committee throughout the year. I also want to thank the NVAC members, ex officio and liaison members, and subcommittee members for their work to further the work of this committee. I look forward to hearing the updates later today. Let's turn to a few housekeeping items, please. In terms of housekeeping, I want to make sure everyone is aware this is a public meeting and it's being webcasted on the HHS website. Please mute yourself when not speaking, and please don't use your camera unless you're presenting, asking questions, or answering a question. During the discussion, I ask that all members and speakers identify themselves before speaking if I didn't acknowledge you by name and giving you the floor. This helps the note taker and others to follow along. Throughout the day, there will be opportunities for committee discussion. If you'd like to ask a question or provide a comment, I'd ask that you send me a message through the chat feature or raise your hand. As always, members of the public will have the opportunity to provide a public comment by phone today at about 4:45 p.m. Public comments are not a question and answer session. They represent an opportunity for individuals who'd like to make a statement to do so. The deadline to request a space for public comments during this meeting is passed. However, anyone can submit a written comment up to 3 pages in length to HHS.gov, and Ann will then distribute those to all of the committee members. Let's go through a few highlights from yesterday's meeting. Yesterday's first panel provided a great summary of the past 35 years of NVAC and framed our future. Dr. Walt Orenstein hit on some of the high points of the history of the committee, followed by important presentations from Amy Finan and Dr. Cravioto, focused on the need for us to maintain strong coalitions and recognize the critical need to consider the world in considering vaccine and vaccination policy. Dr. Edwards summarized some of the challenges and opportunities which COVID-19 has raised, and I closed the panel with my comments on the themes of innovation, vaccine equity, vaccine confidence and communications, and collaboration as considerations for our committee in the next decade. Dr. Shet and Hotez reviewed the impact of the pandemic has had on other global immunization efforts and our need to consider neglected tropical diseases if immunization is truly to be an equitable force for good around the world. Dr. Meals' presentation on WHO efforts to provide smart guidelines and digital solutions for worldwide health promotion was stimulated and brought to mind some of our own information gaps in adult immunization in this country. After the break, presenters from HHS and CDC provided some critical data on the positive impacts of our COVID vaccination program in reduction in disease, hospitalization, and mortality across populations. These data-driven messages need to continue to be widely disseminated to help providers and patients maximize vaccine uptake and minimize COVID-19 disease impacts. The presentation on HHS guidance in prohibiting discrimination in COVID-19 vaccination programs was enlightening and important as we continue to address gaps in vaccination coverage and racial and ethnic disparities in vaccination. The final panel provided some important insights into employer safety and education-focused intervention to get workers vaccinated against COVID-19. These considerations are also relevant to immunization efforts against other communicable diseases such as influenza. Today, to highlight briefly, we'll host panels on the correlates of protection against SARS-CoV-2 infection and strengthening immunization information systems and the use of this data to support public health efforts. After a short break, we'll hear from a panel of experts about vaccine safety, and we'll end the day with federal agency and liaison representative updates, as well as public comments. Finally, as a reminder, please hold our future meeting dates on your calendars. Our next meeting will be June 15th, 16th, 2022, and our fall meeting will be held September 22nd to 23rd. Please refer to the NVAC website for final details on these upcoming meetings. At this time, I'd like to start our first panel of the day on correlates of protection. This panel will focus on work to identify correlates of protection for SARS-CoV-2, including the immune compromised. Our 3 speakers include Dr. Samantha Finstad from the Center for Strategic Scientific Innovations at the National Cancer Institute at NIH, Dr. Kizzmekia Corbett at the Harvard T.H. Chan School of Public Health, and Dr. Chris Houchins, who will present on behalf of the HHS Coordination Operations and Response Element, the H-Core Immune Assays team. This time I will turn the floor over to Dr. Finstad. I see your slides up. You have the floor.
Thank you so much for the invitation to speak with you today about the importance of correlates of protection to SARS-CoV-2 and really the urgent need to understand protection in immunocompromised individuals. So can I have the first slide, please? A correlative protection is a measure of an immune response that's closely related to protection against infection or disease. It's especially useful when it can identify a minimum threshold or level of such an immune parameter that's associated with protection. Now, that threshold can then be used to predict if someone is or is not likely to be protected. A correlative protection can also be used in clinical trials for the approval of new vaccines or evaluating vaccine doses or extending indications to other populations. Now, at the population level, correlates of protection can provide insights into public health measures, such as identifying when a vaccine boost or prophylactic strategies may be needed. It may even provide answers for the questions that we struggle with every day. Do I still need to wear a mask? Can I see my family? If you are one of the millions of Americans that are immunocompromised, these questions are even more pressing. Can I have the next slide, please? So why am I from the National Cancer Institute talking to you about correlates of protection today? The NCI has a long-standing history and expertise in studying virology and immunology as it relates to cancer. Now, at the start of the pandemic, we at the NCI were able to rapidly deploy our expertise in serology testing to support the work of the FDA by testing serology assays at the Frederick National Laboratory for Cancer Research. The FNL Serology Lab continues its work with the FDA and has worked closely with the World Health Organization to develop and deploy a serology standard to the community. Now, in April of 2020, Congress made an emergency appropriation to the NCI to further support those efforts and more. The SARS-CoV-2 Serological Sciences Network, or SERONET, was established to support a broad range of serological sciences research into understanding all aspects of the immune response to SARS-CoV-2. SERONET makes up a collection of diverse cohorts with geographic diversity across age ranges, in underserved communities, and more. And they're collecting longitudinal serological measurements. Studies are focused not only on healthy populations, but also on immunocompromised individuals, such as cancer patients, transplant recipients, and individuals with an autoimmune disease. Now, as a network, SERONET can leverage multiple studies to answer questions that individual studies are just unable to, defining the breadth and the depth of the immune response to SARS-CoV-2, and to understand what contributes to protection in these vulnerable populations, ultimately contributing to finding correlates of protection. Next slide. The current immune milieu for SARS-CoV-2 is becoming incredibly complex. There are different ways that immunity can be acquired, whether it be from natural infection or vaccination with one of several vaccine types, timing of vaccination, adding to that waning immunity and variants of concern. You have different ratios of binding versus neutralizing antibodies, mucosal immunities, cellular or T-cell immunity across all different populations. Now, the different vaccines elicit different immune responses, and the mechanisms of protection may be different. The lack of standardized serology measurements makes it difficult to look at data across studies and institutions, and that's really only for serology measurements. A correlate of protection can be one or more variables, such as antibody binding, neutralization, or antibody effector functions, cytokine measurements, or other B, T, or NK cell measures. Variants of concern may alter a correlate of protection measure if changes in the receptor binding domain of the spike protein result in the vaccine strain being less well matched to the variant, which is one of the reasons we've observed immune evasion to the virus. Next slide, please. Now, often binding antibodies can be used as a first approximation for a correlate of protection. We focus on them because they're relatively easy to measure and are used for other vaccines as well. The SARS-CoV-2 vaccines and boosters increase the measurable immune response, but in the absence of a correlate of protection, we can't yet determine what level is needed to provide a reasonable threshold where we can say whether someone is likely protected from severe disease. Now, to establish a correlate of protection, you need cohort studies where it's known whether or not vaccinated individuals have or have not become infected, and where potentially relevant immunological parameters are known. Now, in this study, using standardized antibody measurements, they show a correlation between spike antibody binding with vaccine efficacy for the wild type and the alpha and delta variants for 4 different vaccine types. And note the log scale of the antibody binding and that there really is quite a variance among the antibody levels elicited by the different vaccines. Now, studies such as these are showing a correlation between antibody binding and protection, but binding or neutralizing antibodies are not the whole picture. They're just one step along the path to defining correlates of protection for SARS-CoV-2. Next slide. The community needs to come to a consensus on what is a minimum threshold for vaccine efficacy. Phase 3 vaccine studies do indicate a correlation between neutralizing and binding antibodies and protection against severe COVID-19, but the correlation between antibody levels and asymptomatic or mild upper respiratory infection is unclear. Even though vaccine efficacy trials have collected serology measurements, not all trials have used them as an endpoint, and the serology assays are not standardized between trials, meaning the trials are not comparing apples to apples when it comes to serology data. The National Serology Standard from the Frederick National Lab can be used to validate and calibrate serology assays, enabling those comparisons between studies, including those for different COVID-19 vaccine candidates. Functional T cell and antibody effector functions may contribute to the control of disease severity. However, we lack clinical or standardized assays to measure those functions. These types of assays are generally very specialized, they can be labor intensive and costly. We also need to understand whether a correlate of protection is different for vaccine-acquired immunity versus immunity from infection. And another consideration is that in these large phase 3 vaccine studies, we only looked at healthy populations, those with an intact immune response. But what of the millions of Americans that are immunocompromised? Next slide. It's estimated that about 3% of the US population is considered immunocompromised, meaning their immune repertoire is different, whether that's because of a disease like cancer, autoimmunity, a hereditary condition, or as a consequence of a treatment, like for transplant recipients. It's critical to study the quality and the durability of the immune response in these populations, especially since they're more likely to have severe outcomes from infection. And we don't have clear answers yet. Another consideration is that these different immune repertoires produce different immune pressures on the virus, which may mutate to evade them. Now, this table shows several different immune scenarios, and you can imagine that someone with a blunted humoral immune response is unlikely to mount robust antibodies following vaccination. But there is evidence that T cell functionality is maintained and individuals may be protected from severe disease, even in the absence of antibodies. Now, correlate of protection in these populations is likely to be different than someone that has an intact immune system. Next slide. I would like to share some of what we know about the immune response to SARS-CoV-2, either following infection or vaccination in cancer patients. Now, cancer can change or compromise the immune system in different ways, either because of the disease itself, through treatments, or both. Now, the graph on the left here shows SARS-CoV-2 binding antibody levels following vaccination in cancer patients. Now, you can see that many don't mount a robust or even measurable immune response, and this is particularly striking in individuals with hematologic malignancies, which is the column in the middle. Next slide. But what about T cell responses in cancer patients? Do they contribute to protection or control in the absence of that robust antibody response we observe in healthy individuals? Now, the data shown here are from hospitalized COVID-19 patients with and without cancer. And you can see that many cancer patients, again, lack that robust antibody response. However, many do have measurable CD8 T cell counts, even in the absence of that robust humoral response. Now, you can see that in patients with a hematologic malignancy on the right, that those with higher levels of CD8 T cells were more likely to recover from COVID-19, suggesting a key role for T cell immunity in facilitating recovery from COVID-19, even in the absence of intact humoral immunity. But further research is needed because there really is not much data in this area. Next slide. But what about people with other immunosuppressive conditions beyond cancer, where one or more arms of the immune system may be affected? Transplant recipients receive immunosuppressive therapy that severely compromises their adaptive immunity, or those with autoimmune diseases who may experience a blunted response. Could alternative options be explored? Are there considerations for vaccination strategies, such as additional doses, higher doses, a pause in treatment around a vaccine window, for example? Or when should we give a prophylactic monoclonal antibody therapy? And what about recommendations about social distancing and mask wearing? Next slide, please. Now, there really is an urgent need to provide answers to the millions of immunocompromised Americans. Now, we're getting closer to having the correlative protection that can be used for healthy individuals, but a critical step, though, is the use of validated serology assays and to report those results in standardized units. However, based on the information we have so far, a correlate of protection based on an intact immune system is unlikely to have the same meaning in immunocompromised individuals as those with a different immune status, like cancer patients. Now, we at the NCI are indeed particularly concerned about these patients. And the NCI SARS-CoV-2 Serological Sciences Network, which is comprised of over 25 academic institutions, is actively exploring these questions. So thank you very much. I'd be happy to answer any questions.
Thank you very much, Dr. Fenstad. Our next presenter is Dr. Corbett from Harvard University. Dr. Corbett, your slides are up. You have the floor.
Thank you so much for having me. It is a pleasure to be with you today. So I'm going to talk a little bit about the data that we do have, albeit limited, around correlates of protection, largely from many of the studies that I did when I was at the Vaccine Research Center at the National Institutes of Health. So we understand where we were then, back in around March of last year, where there was a high level of antibody responses. As you can see here on this graph, everyone who had gotten 2 doses of mRNA 1273 or any of the other vaccines had a very high level of neutralizing antibody responses. Next. But where we, but where we are now is where we have seen, of course, a dramatic decline in those neutralizing antibody responses. And that decline is unfortunately age dependent, where people who are above the age of 55 or so have a more stark decline in their neutralizing antibody responses. Next. So it comes without saying that beyond the wild type versions or the original strains of SARS-CoV-2, there are variants, and those variants a lot of the times do take a hit with neutralization. We saw that, of course, with Delta and Beta, but again, we are seeing that with Omicron even today. Next. So we're about 6 months following the second dose for most people, or far beyond that, even with me, for example, a year out from my second dose, and it is recommended to receive a booster. Next. So I wanted to just kind of give a lay of the land of the types of experiments that inform the utility of boosting. These particular experiments were conducted in the non-human primate model, which has served as a surrogate for understanding SARS-CoV-2 vaccine relevance and immunogenicity. And so we took the non-human primate model and we gave it the standard 2 doses of vaccines 4 weeks apart from each other. That is how you would get the so-called Moderna vaccine. We then waited for about 6 months to follow the trajectory of how humans were when we called upon to boost, and then boosted with either the original mRNA vaccine or the variant vaccine. The colors of those on the following slides will be the animals boosted with original mRNA will be in red, those with the variant mRNA will be in blue. At this time, the most relevant variant was, of course, the Beta variant, and so I'm going to tell the story from that lens, but the data does overlap with Omicron as well. Next. So firstly, looking at the antibody responses over time in those animals that got 2 doses of mRNA 1273, the story is the same as what you saw in the data from the humans prior. The antibody responses, this is the neutralizing antibody responses, does decrease by about a log or a log and a half over the course of 6 months following the 2 doses of that vaccine. Then when you come in next with a boost of the vaccine, you can see that with the boost with that original strain, you get a increase in the neutralizing antibody capacity. And that increase actually goes up beyond what we saw prior to in the peak of the vaccine response following 2 doses of the vaccine. That actually is important to note that not only does that increase happen for the wild type version of the SARS-CoV-2, but then also for a slew of the other variants that had come about, inclusive in this slide up to the Delta variant. And then next, when we compare that to the responses that we see giving a variant mRNA vaccine boost, the data remains the same. So it seems that boosting the antibody responses following the third dose of mRNA 1273 can happen with either a variant or original mRNA 1273 vaccine, and it does not just boost the original responses towards the original SARS-CoV-2, then also to the variant strains. Just recently, next, in a preprint that came out last week from all of us collaborating at the Vaccine Research Center, with the first author being Matt Gagney, shows the same type of data, but overlaying with a Omicron-specific boost. Next. And so we look at protection, and the short of this is that following a boost in these non-human primates, whether they got 3 doses of mRNA 1273 or 2 doses of mRNA 1273 followed by the variant mRNA, these animals were largely protected against severe disease, and that is lower respiratory long viral replication. And you see by day 4, following being challenged with the SARS-CoV-2, these animals had cleared that virus. And this was the beta virus, which is particularly evaded antibody responses from the original 2 vaccine doses by about up to 6 or 7-fold. When we look in the When we look in the nasal swabs, however, you'll see that while there is some clearance of the virus, there is a dramatic decrease on the log scale in the vaccinated and boosted animals. It looks like there is really a difference in that protection level when you look at the lungs versus the nasal swab. So, for example, in that red group, when you look at day 4, about half of the animals had not cleared the virus from their nasal swabs, and this is by sgRNA. Next. We also took those viral loads and nasal swabs and looked at the amount of virus that we could grow out. And you will see actually next that it became very clear that that was somewhat what we call breakthrough of the nose, where those animals that were vaccinated and boosted did have a blip in viral load still in their nasal swabs at day 2 following being challenged with SARS-CoV-2 beta. So next. This goes back to some of the data that we've been seeing all along as we've been studying vaccine responses in the non-human primate. And I tell this story kind of backwards because I like to show that, the breakthrough in the nose, but then also show how we previously determined immune correlates of protection following mRNA 1273 immunization in these non-human primates. So we did this study very early on, and unfortunately, given the times, it is not with the Omicron variant, but it does tell us how when you can dose down in these animals, you can really study how immune correlates of protection might be able to be detected in an animal model. So we studied doses of mRNA 1273 given twice in the standard regimen from 30 micrograms of mRNA 1273 all the way down to a measly 0.3 micrograms of mRNA 1273, and looked very acutely after those animals were immunized to look at how they might be protected following a SARS-CoV-2 challenge. Next. What this slide basically shows is that in a dose-dependent way, you get antibody responses in these animals. So obviously at the highest doses, you get the highest amount of antibody responses all the way down to the lowest doses of 0.3, where the antibody responses starts to dissipate. We looked at various types of antibody responses. The previous speaker was very eloquent in saying that there are definitely different types of assays. One important thing is that understanding that there are some standards that can be used when testing these antibody responses, particularly as we think about them. The international unit standards that are set forth by a World Health Organization panel. We looked at that in these first 2 antibody assessments and showed that we were able to detect in international units the type of benchmarking that we would want to detect in antibody responses across the field. Long story short, it wasn't just for the humoral or the serum antibody responses that had this dose dependency, but then also next for the mucosal antibody responses. So these are not your classical kind of IgA responses as we think about them, but these are the IgG responses that can be detected from the lung fluid in the bowel, and then also in the nasal washes has this dose dependency as well. Next. So we looked at that in comparison to the amount of viral clearance that we got both in the lower airway, as you can see on the left-hand side, and next in the upper airway in the nasal swabs. So I wanted to show this because it becomes very clear that there's this stepwise dose dependent, or as we like to say, antibody dependent ability to protect the animals in the lower airway. As you can see in that pink group, 30 micrograms of the mRNA 1273 has about a 4-fold decrease in the amount of sgRNA or viral replication in the lung. And then there's a stepwise increase in the amount of viral replication as you decrease the dose of the vaccine in these animals. And while you see that stepwise in the bowel, you don't really see that same kind of response in the nasal swab. It becomes very clear that really only the highest amount of mRNA 1273 in this non-human primate, so in this study, 30 micrograms, was able to really decrease the amount of viral replication in the upper airway. So next. What that showed us is that there is a difference between the amount of protection that is needed for the lower airway as opposed to the upper airway in the nasal swabs. We kind of were able to show not only that, but we were after challenge how that might be shown with anamnestic responses. So next, we were able to look at the spike-specific antibody responses following challenge, and you can see that those animals that got high doses in the 30 and 10 microgram and even 3 microgram doses of mRNA 1273 did not have an increase in their antibody responses following being challenged. So what that says is that they probably didn't really have a high level of viral replication following that challenge, which goes obviously to say that they were protected from viral replication and from disease in this particular model. But those animals that got the lower doses and started with a lower level of antibodies prior to the challenge had a significant increase in antibody responses that were spike specific following the challenge. And we didn't just look at the spike specific responses, but next, we also looked at the nucleocapsid specific responses, because these are the responses that are very specific to the challenge, the challenge virus, and showed the same thing. So it seemed like the animals that had lower amounts of spike specific responses prior to being challenged had a higher level of N-specific responses after being challenged. So there was this kind of inverse correlation there. Next. And so we were able to show in just some correlation plots that the spike-specific IgG titers inversely correlated not only with the bowel sgRNA, but then also with the nasal swab sgRNA next. We were also able to show that there was kind of this 1 log change in the amount of spike-specific IgG that corresponds with 1 log change of sgRNA. And this was immediately following the challenge. So this was at day 2 following the challenge in both the bowel and the nasal swab. So that kind of gives you an indication of just how much antibody you might need to decrease the amount of replication in this particular animal model. And next. And we also showed, as I talked about in the previous slide, that there was this inverse correlation between spike-specific antibody responses and the amount of N-specific antibodies. So the amount of antibodies that these animals got following being challenged with SARS-CoV-2 that was specific for their virus, there was this inverse correlation saying that the more antibodies you have, the more protected you were from viral replication again. Next. And so it's one thing to show that antibodies correlate with protection, but there's another way to go about this to be more mechanistic about it, to show whether or not antibodies are actually in fact sufficient for protection. So we took antibodies, IgGs, from those monkeys, and we passively transferred them back into a more pathogenic hamster model. Next, and we did this in a dose dependent way. So we gave 10 mg of the IgGs versus 2 mg of the IgG, and obviously compare that to a negative control of pre-immune IgGs, and we're able to show very specifically that mRNA 1273 immune IgGs from those non-human primates that had been vaccinated was able to protect these hamsters from losing weight. And so what this showed us is that the IgGs were sufficient for protection. Next. So what we show here is that as you increase the amount of spike-specific IgG titers, you obviously are able to decrease the amount of viral replication in the lower airway and also in the upper airway. Next. So where we were then, back in around, March, April, the early parts of the summer of last year, is we had high levels of antibody responses that were able to protect us against lower and upper respiratory disease from the SARS-CoV-2. And that is in the context of the original strain. But where we are now, next, is that we have obviously had some time that has passed. So there's antibody waning, variants are circulating, and there's new variants kind of on the wake of circulating at any given time. But the vaccines have largely been protective against severe lower airway disease. And that's probably because of this disparate amount of protection that is needed when you look at antibodies, both in antibody responses and the threshold for protection in the lower airway compared to that in the upper airway. Next. So I show these data because these are one of the few studies that shows the durability of protection following just 2 doses of the COVID-19 vaccine. And this is again in the non-human primate model where the vaccine was given in the standard 0-4 week with 100 micrograms of mRNA 1273. And the animals were challenged about a year later without boosting at all. And what you saw is that next, while we don't see that protection at day 2, like we have seen previously, immediately following the 2 doses of the mRNA 1273 or following a boost with mRNA 1273, what we do see is that those boosted animals do clear the virus still by day 4 following challenge, particularly in the lower airway. We don't really see that as much in the upper airway. As you can always say, in the upper airway, there is a little bit of breakthrough, and we kind of see the same kind of breakthrough, obviously, in the human population as well. Next. But the interesting thing about all of these data that come together in this paper that we published in Cell is that in this case, the correlates of protection for antibodies actually do not pan out because it is a year later following 2 doses of the vaccine. So in the long story short is that correlates of protection can obviously change over time. That is important for us to remember as we think about correlates of protection and how to assess them, particularly in the pandemic setting, or as we move into a more endemic setting. Soon after vaccination, the correlate of protection was very strictly antibody responses, binding antibody responses, and also neutralizing antibody responses. But later after vaccination, it seems that as you dive deeper into it, that it becomes more about the anamnestic responses. So how quickly do those memory responses come up following the animals being challenged, but then probably also as you think about a human being and getting a breakthrough infection. And then correlates of protection may vary with the severity of the disease. And then lastly, as was said in the previous presentation, antibody responses are an easy way to measure correlates of protection because they're easy to measure in a laboratory setting. They're easy to monitor, and they allow for an attainable bar for us to set for future vaccine candidates. And I think that's my last slide. And thank you.
Thank you very much, Dr. Corbett. Our next presentation is Dr. Christopher Houchins from BARDA. Dr. Houchins, your slides are up. You have the floor.
Great. Thank you very much. And thank you very much for inviting me to this meeting. Again, I'm presenting on our efforts, the U.S. government's efforts to identify correlates of protection for our U.S. government-sponsored COVID-19 vaccines. I'm speaking on behalf of the HHS Coordination Operations and Response Element, which is HCOR. It was originally Operation Warp Speed and then Countermeasures Acceleration Group. So I'm going to refer to a number of those different acronyms perhaps throughout this talk. Next slide, please. So the U.S. government's Operation Warp Speed was established in May 2020 to accelerate the discovery, development, manufacturing, delivery, and administration of safe and effective diagnostics, therapeutics, and vaccines against SARS-CoV-2. Next slide, please. To support the U.S. government vaccine development efforts, the Immunoassay Working Group was stood up to establish correlates of protection for each of the vaccines being developed under Operation Warp Speed. As Dr. Finstead really articulately spoke about, establishing a correlates of protection, which is an easily measured biomarker like an antibody, can be used to predict vaccine efficacy based on immune responses in vaccinated individuals, which can then be used to accelerate clinical development of future vaccines, expand vaccine availability to special populations, and guide modifications for use of vaccines with regard to dose, boosters, and strain updates. Next slide. So how can a correlate be used to accelerate vaccine development? So normally establishing vaccine efficacy requires the conduct of a large, randomized, placebo-controlled phase 3 clinical trial involving tens of thousands of subjects and requiring 6 months or longer before results are known. If we can establish a robust correlate, then smaller studies with fewer subjects can be conducted much more quickly in order to predict vaccine efficacy. So establishing a correlate is also important, as it may be impossible to enroll enough volunteers in traditional large randomized phase 3 studies for a new vaccine if other authorized or approved vaccines are currently available at that time of the study. Next slide. To establish correlates for OWS-supported vaccines, the immunoassay team established a network of labs to develop, qualify, and validate immunoassays for the testing of sera samples from individuals vaccinated in registrational phase 3 studies. Working with academic partners, the immunoassay team also developed and implemented statistical plans for conducting correlates analysis. And finally, the immunoassay working group worked with vaccine manufacturers to transfer samples from phase 3 registrational studies to testing labs to conduct a variety of immune assays, including binding antibody assays, pseudovirus assays, and live virus neutralization assays. Binding and neutralization data generated by the testing labs, along with data on infections, were then sent to our correlates team at the Fred Hutch Cancer Research Center to establish correlates between antibody levels in vaccinated individuals and unvaccinated individuals, and then monitoring their infection status. Next slide. The network we established included academic labs that developed the original assays that were then tech transferred to CROs to provide additional testing capacity. The NIH's Vaccine Research Center developed an MSD binding antibody assay that was validated and then tech transferred to the CRO Nexellus. Both Duke and Monogram independently developed their own pseudovirus neutralization assays, and these assays were calibrated to demonstrate that results generated on one platform could directly be compared to results generated on the other assay. And Battelle, under a contract with NIAID, established a live virus neutralization assay, which was then tech transferred to microbiologics. Next slide. We also established a testing and correlates analysis plan that was roughly broken down into 2 stages. Stage 1 is focused on collecting peak immune sera following vaccination and following these subjects for the first few months to obtain infection data that, together with antibody levels, allows us to establish correlates for that vaccine. Stage 2 represents our longer-term efforts to collect sera and follow the infection status of subjects for up to 2 years following study, unblinding, and establishing durability of vaccine efficacy and correlates against evolving variants, including Delta and Omicron. Next slide. So this slide is just a snapshot of the 6 vaccines that have been supported by the US government under Operation Warp Speed, or the CAG, or now HCOR. So what you can see is that we have three distinct vaccine platforms, including 2 mRNA-encoded vaccines developed by Moderna and Pfizer-BioNTech, 2 viral vector-encoded vaccines developed by AstraZeneca and Janssen, and 2 recombinant protein-based vaccines developed by Novavax and Sanofi. We expect that the diversity of the vaccine platforms will provide us with very rich data sets regarding correlates of protection associated with various vaccine types. An analysis of combined data sets across the 3 platforms will also inform on the consistency of correlates of protection across trials, populations, and vaccines. In addition, this diversity allows us to analyze the same markers when evaluating next-generation COVID-19 vaccines currently in the pipeline for improved durability and breadth of protection. Next slide. Because many groups developing COVID-19 vaccines need timely evidence as to the quality of antibody markers as correlates of protection, we decided to report the first immune correlates results for the Moderna vaccine phase 3 study as a preprint posted on August 9th. We followed this up with next slide. We followed this up with a peer-reviewed Moderna Correlates paper that was published on November 23rd. Its authorship comprised laboratory investigators, statistical investigators, clinical trial site investigators, part of the Coronavirus Prevention Network, Moderna investigators, and the U.S. government leadership for the Correlates of Protection studies. So the next couple slides, I'm just going to go through how the study was conducted and our results. So next slide. So the Moderna Correlate study assessed the antibody markers measured at 4 weeks post-dose 1 and 4 weeks post-dose 2 as correlates for symptomatic COVID-19 infection endpoints occurring over 4 months post-vaccination during an era when only Wuhan virus strains were circulating in the US. Future Moderna Correlates analysis being planned will study how well antibody levels predict vaccine efficacy against variant strains such as Delta and Omicron. Next slide. So from our study in vaccine recipients, you can see that antibody levels at 4 weeks post-dose 2 were inversely correlated with the rate of COVID-19 symptomatic infections over 4 months. The plots that you see here show that both IgG antibody concentrations to the receptor binding domain of spike on the left and pseudovirus 50% neutralizing antibody titers were inverse correlates of risk. The risk of acquiring COVID-19 was estimated to be about 30 times less for vaccinees with the highest neutralization titers of 10,000 IU50 per mil compared to vaccinees with undetectable neutralization titers. Next slide. Using a causal inference method, this graph shows the results in terms of how neutralization titer at 4 weeks post-dose 2 impacted the level of vaccine efficacy. What you can see is vaccinees with lower titers of 10 international units have an estimated vaccine efficacy of 78%, compared to vaccinees with titers of 100 and 1,000 international units with estimated vaccine efficacy of 91% and 96% respectively. The fact that vaccinees with lowest neutralization titers still receive partial protection from vaccination implies that this immune marker does not fully explain the protective efficacy of the mRNA vaccine. However, neutralization titer was estimated to explain about 2/3 of the protective efficacy, which is an impressive enough proportion that it supports utility of this marker for guiding vaccine research and approval. Next slide, please. In summary, these results show that we observed a strong correlation between vaccine efficacy and antibody titers at both 4-week post-dose 1 and dose 2 time points for each antibody marker. And pseudovirus neutralizing antibody mediated close to 2/3 of the overall vaccine efficacy that we observed of 92%. These results also strongly support neutralizing and binding antibody biomarkers as correlates of protection supporting vaccine decisions. Next slide, please. So looking forward, we're going to continue to use these capabilities that we established to develop correlates of protection for other vaccines, whose development we have supported, as well as for next generation vaccines that we may consider supporting. Besides correlates of protection, this network is also being utilized to evaluate immunogenicity of current vaccines against new variants and stage 2 testing of late phase 3 trial time points to determine vaccine durability and the impact of variants on vaccine efficacy. And lastly, this network will continue to support testing of vaccines in pediatric populations, as well as serving as a critical resource for supporting the development of updated vaccines against variants resulting from seasonal or geographical fluctuations. And next slide, I just want to say thank you again for giving me this opportunity to present on the work of HCOR and the immunoassay team, and happy to take any questions.
Thank you, Dr. Hutchins. I appreciate all of our presenters, Dr. Finstead, Dr. Corbett, and Dr. Hutchins, all very stimulating talks. Our first question for discussion comes from Daniel Hoft. Daniel, you want to take the floor?
Sure. Sorry, took me a while to unmute. So I'm interested in the other side of the adaptive immune response that could be relevant here, the T-cell response. And I'm wondering, 3 questions related to that. whether or not there's been any NHP studies set up pending that will be looking at mucosal vaccination data, which maybe not is just focused on T cells, but is an important thing to try to get a better protective response against the upper airway replication and potentially protection against transmission. Second, I put these in the chat, but I'm just sort of expanding on them, I guess. The second question is, it seems like to get at whether or not T cells really can protect, which there's data that is suggestive of that so far. In the NHP model, at least, we should be able to deplete B cells, vaccinate with, say, the Moderna vaccine, and then see if there's any protection that was induced by the vaccine against a challenge. So I wonder if anything like that is being planned or underway. And sort of the general question then is, how else can we develop additional data to help us establish a T cell correlate of protection? Thank you.
So I can probably take some of these questions. Well, thank you. I think these are very good points. To answer the first question about the NHP mucosal vaccination data, to my knowledge, there is none yet. There are several groups, also companies, that are working towards trying to understand how we can get better mucosal immune responses. And so I think that there will be, at least with the collaborators that I have, I do know that there will be some NHP studies around mucosal vaccination that will be starting, particularly around boosting of the mucosal responses that we already might have kind of transiently hanging around. And then the effect of B cell depletion. So we thought a lot about this and about doing these kinds of studies. Well, they're very intense studies to do. It's not that easy to deplete B cells from non-human primates. And we thought that kind of as the correlates data was coming out, it became clearer and clearer that B cells and then obviously antibody responses had a lot to do with the correlates of protection. And so we kind of sidelined those studies to some degree. As you saw kind of in the last presentation, it is only a part of the entire story. And T cell responses have been coming up a lot, particularly as we think more and more about the variants and as the antibody responses wane. What I can say is that in the non-human primate studies that I briefly showed data from, there are figures in there that show the memory B cell responses, and also, especially in that one paper where we looked at the protection in the non-human primates following a year, there is a lot about the T cell, particularly the anamnestic T cell responses that might play a role in those monkeys that have basically undetectable or very little neutralizing antibody responses following a year. So T cells definitely have some role, especially as we think about severe disease and lower airway protection. But how we can really study that, and on how we can detect T cell responses on a population basis, or use it as a correlate to bring in future vaccine candidates is still really up for debate, because T cell responses are not that easy to study out of the context of non-human primate models.
Thank you.
I guess I can add to that a little bit. With T cells, we have a bit of a measurement problem, as Dr. Corbett was saying. They're difficult to measure, and in immunocompromised patients, we are following cohorts and looking at T cell correlates, but because of the difficulty of measuring the T cells, and are we measuring CD4 cells, CD8 cells, effector functions, cytokines? There's many things to measure, so it's unfortunately not an easy answer.
Just one last question, then, if I could. Is there any interest in looking at specifically vaccinations in B-cell deficient people, where, of course, the antibody response can't protect.
Well, that's something that the National Cancer Institute is extremely interested in, and some of the data that I showed you from an Albert Einstein group is specifically looking at that in cancer patients. Many with hematopoietic malignancies do not have high levels of B cells, or they're on B cell depletion therapy, which impacts their immune response. So we are looking at the immune kinetics in those patients.
Thank you very much. Great presentations.
Our next questions come from Jeff Dusha. Jeff, you have the floor.
Good morning, and thank you for those amazing summaries of this really incredibly important work. My questions are maybe a little bit more on the mundane and practical end of things, but I'm curious about your assessment of how close we are in time to having a sero-assay that we can use, in public health or commercially, and that can provide us with some evidence of immunity in people with past COVID-19, as we have for other vaccine-preventable diseases. And secondly, how do you see the results of such testing potentially influencing dosing schedules of COVID-19 vaccines, for example, number of doses needed or timing of doses?
So this is Chris. Maybe I can take a first shot at this because I think I'm more of the mundane operational person here. So I would say, to answer your first question, with the work that we're doing, this is a little bit out of our remit to develop these capabilities that are going to be used for general commercial use to provide evidence of immunity in people with past COVID-19. Really kind of the infrastructure that we've developed here, at least I would say in the near term, has really been established to support the development of vaccines that are within the U.S. government's, portfolio. I could see that some of these capabilities, though, especially with our CROs, could provide that, that as a resource, as a general commercial resource for doing these kind of studies in the future. But I would say I don't really have an answer. I couldn't say what we've developed under Operation Warp Speed or HCORE is really a resource that's going to be more broadly available. But I do see, really kind of regarding your second question, do we see the results of testing for correlates having implications for dosing of COVID-19 vaccines? Absolutely. That is the reason why we are doing this, because we want to be able to, we see having correlates really having two significant roles. One is we want to be able to accelerate not just the development of new vaccines or next generation vaccines, but also how, to help our stakeholders and decision makers, make informed decisions about how we're going to use our current vaccines with regard to, how often we boost, the size of the doses that we're going to administer, basically being able to get to the answer much quicker than having to conduct larger, phase 3 studies. We see the correlates as really helping to inform the operational use of the vaccines that have already been developed, and also to support the development of new vaccines, next generation vaccines. And really importantly, we need to have this capability, or we need this information, because we're not going to be able to conduct large, phase 3 randomized registrational studies in the future when we have other approved or authorized vaccines available. So being able to make or predict vaccine efficacy based upon, smaller studies that we're able to conduct much more quickly will not only allow us to get to the answers quicker, but also make the studies much more feasible. So I don't really have an answer to the first one, but I would say, yes, I would agree that these results are going to be critical in making some of those strategic decisions going forward.
Thank you.
Rob Schechter, do you want to ask your question?
Bob, can you hear me?
Yes, you're loud.
Thank you to all the presenters and the work represented, all the work represented in. I'm just wondering to what degree, I guess thinking about that the same sort of bridging and correlate metrics are used year to year for seasonal flu vaccine, but I'm wondering to what degree it's reasonable to expect that correlates will be generalizable between variants. And if you're using a variant-specific assay, that a titer that's correlated for an older variant will offer similar protection to a newer variant.
So I don't have the answer all the way for your question, but I do want to say that one of the reasons why I didn't even speak on the titer that I had on the bottom of that one slide, which was, I think, a binding titer of about 500 international units per mil, which would be considered to be protective in the non-human primate. And I do remember it being in the 2 log scale for the human study as well. But they also, and I can be corrected obviously, but I think they also kind of were not so strict about saying that really in the paper, because having a very strict number is, number one, it's not necessarily that easy to measure, but it is really just that. It is kind of an easy indicator, but it's not an end all be all. And so many different people, depending on how many T cells or whatever else might be happening with them that they have, it could be different. And so we try not to say a lot about a very strict number. So I kind of want to remind everyone of that as we have the discussion. And I forgot the first part of the question. Sorry.
I think you've addressed it to a large degree, but to whether on a population basis or individual basis, if you had a correlate for an ancestral variant, to what degree, if you're changing your assay for a newer variant, to what degree that there's that same levels or range would be expected to provide similar protection against the newer variant?
And that is a very good question, especially because largely, particularly on when we think about neutralizing responses, largely neutralizing responses are targeted towards the receptor binding domain, which variants of SARS-CoV-2 have been shown to escape receptor binding domain antibodies fairly quickly. And so that is why we really base our correlates on the binding antibody responses. But even then, right, there are so many things that go into the falling out of binding specificity as variants accrue more and more mutations in the spike protein. So that correlate, the correlate of protection being binding antibodies, I think probably will go across variants, but I don't necessarily think that number, for example, the 400 international units per mil would be the same across the different variants. And that is actually something to think about, aside from all of the other caveats that I spoke about just now previously. It might be higher or lower, and because it is already a higher threshold in the nose, particularly from those variants that tend to kind of like to hang out in the nasal cavity and be more transmissible, we might have a higher threshold there. So that is actually definitely something to think about.
Thank you again.
And our final question for this discussion is from Tim Cook.
Thanks so much. I'm so glad to see this kind of work going on. It's great. I wondered if there's any kind of formal mechanism for collaborating with the FDA. I mean, ultimately, they're going to have to work these correlates that I hope we get to into their, regulatory processes. I just don't know if there's cross-agency working groups or how is that happening?
I mean, I can speak for us. So the immunoassay team does have a weekly meeting with the FDA. Mm-hmm. The FDA has been very much involved in the studies that we've conducted, the establishment of the statistical analysis plan. We briefed them even before we initiated any of these efforts, just to make sure that they were aware of what we were doing, to get their buy-in. And we've kept them up to date as we go. And as I said, we meet with them on a weekly basis just to update them on the progress that we're making. So they're very much aware of this.
Mm-hmm. Great. Thanks, Chris.
All right. I want to thank our members of this panel. It's been a very good presentations and stimulating discussion.
produced by the U.S. Department of Health and Human Services.